let's jump in. I have a lot to share today. And for those of you who don't know, it's a pleasure to be here. I am an interventional cardiologist, which means my job is to try and stop a heart attack in its throes, to try and alleviate symptoms, is really how I was trained. And so, what life and what research showed me, which is why many of you are here, is the fact that there is actual power in terms of what we can do on our own to do accomplish just that. So that's what I want to kind of really dive into here a bit. And I have a lot to kind of go through, and so let's sit back. So we're going to dive into this idea. And so as a cardiologist, I have to really kind of start with the patient, right? So it's always about a patient. So I'll never forget this patient. I went in, I was in the cath lab. In the cath lab, for those of you who are not aware, this is an area where we go in and we perform procedures on the heart, as I mentioned. And so I'll meet patients inside of our recovery bay, and I'll introduce myself. They're my colleagues' patients. And so I met this gentleman that was there. He's a 55-year-old. He appeared younger than his stated age. And so he was sent over because he had this new onset symptoms of just this discomfort, this pressure, this shortness of breath. But when you looked at him, he looked pretty fit. He was 5'9", about 160 pounds. Blood pressure looked great. It was 108/69. But as I started to parse through the chart, I noticed something that was distinctive. His cholesterol panel had all red marks by it. Total cholesterol was 268. Triglycerides were on the higher side, 215. His low density lipoprotein cholesterol value was 178, and his HDL was at 47. Now, he had undergone a test prior to being sent over. And what we'll do is we'll do imaging of the heart muscle itself. And we'll do that before we put a person on the treadmill or infuse medications on them with them. And then we'll do it afterwards. And we're looking to see, are there any segments of the heart that don't appear to contract, thicken quite as well? And so there was an area, very subtle area, that was identified that said, well, there could be a slight defect that we see here. So I brought him into the cath lab where I performed this procedure. And so we insert this special plastic tube inside the arteries, and it travels to the heart itself inside the aorta. And just outside the aorta, we inject a contrast, a fluid that allows us to visualize it and take short images. And so your vessels should be all equal caliber, meaning the same size, and slowly begin to taper down like a big tree. But what we saw in his case, he had multiple areas where there were narrowings all throughout his vessels, greater than his apparent stated age. And as I sat and I spoke with him about really the options, and the options are, we can go aggressive lifestyle with whole food plant-based nutrition. We can go inside of the avenue of attempting surgery or stents, depending upon which avenue, based upon his symptoms, his presentation at the time. And so if we can go back in time and really stop this crime before it happened. Now, I'm not sure, I'm a movie buff, and my family is too as well. And there was a movie Tom Cruise did years ago called The Minority Report. And this was about a police officer who would go back in time and he would stop the crime before it happened. He would arrest the criminal before it happened. And as I searched through this patient's charts, I saw that his history went back many years ago. And so our sole goal is always, when we look at this trajectory of an event, we understand as we move left to right that we look at the vessel that's inside this mid image. It shows no atherosclerosis. And as you move towards the right of the image, you start seeing this slow rise, almost like a mountain that becomes a volcano, this volcanic eruption before it starts and it erupts. Can we somehow intervene? Can we stop this progression of plaque? And what exactly is this plaque? And so that's really the goal of saying it. And so as we went through and we looked 15 years earlier when he was 40, I saw that as I looked back through his records, his total cholesterol was even higher at 294. His low density lipoprotein cholesterol was even higher at 214. His HDL was at 52, and his triglycerides were at 145. And I saw that year after year after year, he was exposed to this risk. And the question is, what didn't his doctor tell him in that moment? Well, the one thing we have to understand first is that, well, when should I check my cholesterol? Well, if I'm at high risk, if I've had multiple family members who've suffered with a heart attack, if I'm a man and I had family members who had a heart attack before the age of 45, I'm a female, I had family members heart attack before the age of 55, I may be potentially at higher risk. If I have diabetes, if I'm a bit overweight, if I have high blood pressure, these are areas that pose a higher risk that says I should maybe start having my cholesterol checked my lipid profile checked at the age of 30. If I'm lower risk, maybe at around the age of 40 and begin. But then the question arises, what is this thing called cholesterol that leaves so many of us so questioning and befuddled, and we hear so much information? Well, I think it's first we have to recognize it's not all bad news. That cholesterol is essential for the body. We understand that. It's part of our cell membranes. It is a precursor to bile acids. Now, I bold that because I want you all to hold me accountable. I'm going to come back to this bile acid issue here a bit later on. It's also precursor of steroid hormones. But when we look at cholesterol, cholesterol is not just one entity. It's a multiple components. And so we understand that there is a central lipid core. Now, many of you guys have used oil. You know what oil is, whether or not it's you use it for cooking or other things of that sort. And I'm not going to get into that immediately, but we'll touch on that a bit later on. If you were to put a drop of oil inside of the water, it will not dissolve. And so it needs a carrier protein. And so we understand this carrier. So cholesterol is like a ship, right? And so it's carrying a lipid-rich center that's there. It's encased in what we call a protein that allows it to travel in the plasma, which is a hydrophilic component. And then the lipid itself is what we call hydrophobic, which means it doesn't dissolve. And so when we start to look at this and we break it down molecularly, as I mentioned, the hydrophobic core is rich in triglycerides and cholesterol esters, but the outer portion is really wrapped and encased in proteins. Lipoproteins are really what constitute it, along with phospholipids there. And so we know that there are multiple sizes in terms of what we see as it relates to. So cholesterol and triglycerides, they're insoluble inside of the water, and therefore these lipids they're transported in association always with these proteins. So you think of it as a cargo ship and it's transporting. And so it becomes very complex. We look overall, you have to the right of the screen, very large particles. And as they begin to go through the process, they begin to get broken down. And so you can have a source that happens endogenously that are produced naturally. And so we understand some of us will produce more cholesterol, and you have it exogenous, which means from our dietary intake. And so we understand that these lipoproteins, which is really what we're talking about, that encasement, part of the ship that's there, can be divided into 7 classes based on size. So what size of ship are you on? You're on the Titanic, which is the chylomicron, very large, and all the way down to maybe a small tugboat that's there, and so you're going all the way through. And as I mentioned, these have all different levels of size, and they also can cause potential harm based upon that size. The smaller they are, typically the remnants, you're going to get into more of the harm. We're going to get into that because, once again, you have your exogenous and you have your endogenous. And so we're looking at two different stratas, two different pathways to developing the cholesterol. So we look exogenously, which is from the standpoint of what you eat, right? So if you're having the avocado toast, if you're having burgers and fries, if you're having, Oreo cookies, if you're having all these different things, maybe you should or shouldn't be having that we know that this is being absorbed in the body. So the exogenous, the absorption, I'll tell you, the transport of all this dietary cholesterol, these lipids are incorporated into the largest one, the chylomicrons. And this is inside your intestine. And these chylomicrons in your lymph system, right? And then into your bloodstream, where they deliver the internal component. They're mainly comprised of triglycerides on that inside. And it delivers that energy to the muscle and the fat tissue, the adipose tissue. And then it's broken down, and the remnants of the chylomicrons, which are very going to be rich in cholesterol, those are taken back to the liver. And that makes sense, right? We talk about fatty liver from just the process of things that we're eating. And this is part of that process. But you also have it where your body is making this endogenous pathway, and cholesterol made, and it starts off as what we call VLDL, and it becomes broken down to IDL, intermediate density, and it's all based on the size and the density of the cholesterol and how much triglyceride is present there, or fat itself. And so we understand that there are multiple components of this. So not to get into all the biochemistry, but when we look at what we're measuring on the lipid panel, we understand we typically only measure 3 things. One is the total cholesterol. The second is your triglyceride level, and the third is your HDL. And so when we look at these 3 components, everything else is a calculation of these 3. So when we talk about lipid profile, what precisely is it measuring? So your total cholesterol is going to take into account everything that's there. It's taking into account all of the VLDLs, your intermediate and your low density lipoproteins. We're looking in terms of your HDLs. We're looking at all these varying components, and this is what the total cholesterol looks at, which means it's going to take into account your triglycerides. It's going to take into account the HDL, and those are extremely important because when you start to break it down, the triglycerides, once again, this includes the chylomicrons. So this is where your body, basically all the fat is stored, and it begins to break it down into the various components. This is so important because when your triglycerides are going to be a reflection of your dietary intake. So I'll know if a patient comes to me and they tell me that, hey, doc, I've been eating well, but their triglycerides are 200, 300. It tells me that they're having a lot of processed foods. They're having a lot of fatty, rich foods because that's what happens immediately. And that doesn't last in your bloodstream very long. That's why we'll either have a fasting blood lipid profile or we'll have a non-fasting lipid profile. Now, it also measures your high density lipoprotein. And these have historically been denoted as having involved in reverse cholesterol transport, which means they help remove some of the cholesterol and bring it back to the liver and so forth from the tissues, and hopefully helping to offset some of the atherosclerosis. But we know it's much more complicated than that. They also possess anti-inflammatory, antioxidative, antithrombotic components. But when we look, so those are just the sole three things that are measured. When we look at what is not measured, right, and what's calculated are actually your low density lipoprotein cholesterol and your non-high density lipoprotein cholesterol. This is what we're concerned about. These are the things that historically have been told are the ones that are causing the most harm, but it's not even that simple. We look at the LDL, we look at LDL cap, it's measuring the amount of cholesterol in each of the components. But this graph here tells you that there are different sizes of your LDL. And so when I'm looking at the cholesterol, if I have my large buoyant cholesterol and low density lipoprotein cholesterol, think of it like a large beach ball. That beach ball, it's not going to cause much harm. You throw it, it hits you in the face, and you're okay. You might be a little annoyed, but it hits you in the face, you're okay. But as I make that more dense, all the way down to a golf ball, and I throw a golf ball at you, that golf ball can cause significant harm. But that's a difference in the density of the component. So when I'm measuring just solely the cholesterol content, I may miss the fact that my golf balls don't have much cholesterol content. And I may say, oh, you don't have very many of the low density lipoprotein cholesterol that's there, so you're okay. That's not exact. That may or may not be the true because I'm looking at the golf balls are smaller and don't have as much cholesterol, so I may miss it. So there's a discordance between the measurements that can be had. And so on large population levels, LDL cholesterol, which is what the C stands for, is probably reasonable to try and say across the board to lower, but on an individual level, it may miss some of the risks that you pertain. So this is a calculation that looks at your LDL, total cholesterol minus your HDL, minus your triglycerides divided by 5. And so this can be useful in the absence of extremely high triglyceride levels, right? It can be useful in terms of as I mentioned before, when your LDL is very low, it may still not be reflective of the true risk. Non-high density lipoprotein cholesterol is another value that's calculated. And this gives us a sense of all the atherogenic particles. This may or may not be reported on your lab work, but your doc can simply calculate this fairly easily too as well. And so this is why we have to ask what your lipid panel isn't telling you. May not be telling you your full risk. That discordance between your LDL-C, the cholesterol content, the size, that beach ball versus the golf ball, may not be able to be discerned easily based upon the values listed inside your standard lipid protocol that's there. So what's the alternative? Apolipoprotein B. Apolipoprotein B, think of it like if it's the branding, right? It's a branding. Or I always like to say it's like, if it's a police car that's there, right? So we want to identify all the police cars, but you can have different ones. You have motorcycles, you may have SUVs, you may have different cars that the police will drive, but you can always identify the police car based on the sirens. The sirens that are there that are embedded in the lights or on top of the hood or wherever they are, that will be something that always wraps you back in. And it's a marker. It is a stamp that's there. So apolipoprotein B is like that marker that tells us that this is associated with an atherogenic particle, a particle remnant size breakdown of cholesterol that can cause harm, part of that boat, the identifier marker on the boat. So whether or not it's your VLDL, your IDL, your chylomicron, your LDL, these markers are all contain the apolipoprotein B, which makes it so valuable in being predictive of future events. So one of the things that we always want to be aware of is what our apolipoprotein B levels are, because it gives us a sense. And so even in patients who are on statins and are on medications for it, we understand that when their LDL is high, but their apolipoprotein and non-HDL is low, there's no increased risk. When their LDL is high and but their apolipoprotein is, excuse me, their LDL is low, but their apolipoprotein is high, we know there's an increased risk, right? And the same goes on the other two as well. High LDL, high apolipoprotein, that's an issue. So this apolipoprotein and non-HDL are better predictors than your LDL. It doesn't mean that cholesterol's false. Doesn't mean we're talking about it's a complex. We're looking at the carrier protein and we're looking at the lipid core that's there. And we understand once that lipid core gets embedded inside of the vessel, that's when the process of atherosclerosis begins. So it tells us that lipids actually matter, that our cholesterol matters, that cholesterol is once again the main lipid in the arterial plaque. It's carried by these apolipoproteins that carry it to the wall. And this allows the particles to move through the plasma and bind to the cell receptors and start this whole cascade that begins to occur. You have to really visualize your vessels, the lining of your vessels, almost like a volcanic eruption, like pimples that happen, right? You think of pimples inside of kids that are there. And so they'll get the small bump. It might start to get a little red and inflamed, and it gets what inside of it? It gets the pus that happens. And as it gets larger and larger, eventually that pus the skin may break at a weak point that allows the pus to come out and be expressed. Well, the same thing happens on the inside of the vessel, except when it breaks and the pus is allowed to, or the inflammation pocket is allowed to be exposed, your body goes into overdrive trying to heal that with clot, and that's how a heart attack happens in that moment. So when we look at studies overall, whether or not we look at low density lipoprotein or ApoB, we know that the higher your risk, the higher your levels, the more likely you are to have evidence of atherosclerosis. So I just got back into town and I met with some cousins, and my cousin's wife told me about her cholesterol profile, and I probed a bit, and as she showed me, her low density lipoprotein cholesterol had been as high as 300s. So I began to tell her really about this persistent exposure and what that means in terms of her vasculature throughout her body, and the likelihood that she has features of atherosclerosis or coronary artery disease or hardening of the vessels at some vascular bed, whether or not it's her brain, whether it's her heart, whether or not her abdomen, and the importance, the imperative nature of trying to bring that down. We look at small kids. When you're born, your low density lipoprotein is around 50, 55. Right? And we're seeing that the levels are markedly low, but they rise as we get older, as we begin to have life happen and we partake of certain foods. We know, once again, the longer our exposure, that when we have severe high cholesterol from a young age, the left of the screen, that the onset of atherosclerotic vascular disease, the dotted line that's horizontal, happens a lot sooner on that red mark. If it's moderate, it happens a little bit later in life. If it's mild to modest, it happens a little bit later. But if we're able to keep it low, we drop that slope down, and the likelihood of us developing it begins to be diminished. And that's what our goal is. Can we decrease our risk? That's what it's all about. Now, this study is very interesting in terms of, once again, it's looking at the level and the impact, irrespective of your age, that as we allow our low density lipoprotein cholesterol. Now, remember, I already told you this isn't even your best predictor, but a lot of studies that we have available to us are based upon this low density lipoprotein cholesterol, LDLC. And it still tells us that when that LDLC, according to every single age group, is high, The higher it is, as you go backwards, you're at a high level of risk, and essentially your cardiovascular age is much higher. That's where the problem is. And so we know, once again, as the levels go up, our rate and our risk of cardiovascular disease rises exponentially. Now, I gave you the personal example of a family member whose bad cholesterol was still in the 180s to 200s. Her risk is very high. And so our need is to lower that risk to minimize her likelihood of having an event. So we become very concerned when the low density lipoprotein cholesterol is greater than 190. We begin to wonder, is there a genetic predisposition? Is there a relationship with familial hypercholesterolemia? Is this a result of the body producing too much? And we begin the process of looking at what else can be done, and because we understand that the risk is high and we have to turn that risk down low. So when I see patients like that in my office, one of the first things I'm doing is we're saying, I need to calculate your risk. And this is a complex slide, but one of the first things I'm doing is I'm saying, I want you to remember this tool. It's called the atherosclerotic cardiovascular disease risk assessment tool. You can download it, you can plug your own numbers in, and we're looking to see what is the threshold, what is our risk over 10 years. That's the first thing that I'm seeking to try and understand. So it's going to look at things like your age, your sex, your race, although there's been newer versions that have come out recently that have not looked more at social determinants of health as opposed to specifically race, since genetically we're all the same. We're all the same, right? Just wrapped differently, but we're all the same. Looking at total cholesterol, our HDL, high density lipoprotein, our blood pressure. Do we have a history of high blood pressure, diabetes, or currently smoking? And this begins as we plug this data in, it tells us our level of risk. Is our risk high or what's low? So you say, well, okay, well, how do I know what's high and what's low? Well, what we've established within the American College of Cardiology is a risk point of 7.5% over the ensuing 10 years. And how that was pertained was looking at the level at which intervention, now this intervention, of course, from a traditional medical perspective, was solely looking at the use of statins, at pharmaceutical agents, not at aggressive lifestyle. At every level, there is no harm with proceeding with aggressive lifestyle intervention. But we identified that 7.5 would have the least amount of harm to individuals at that level, with gleaning still the greatest benefit. And so that's why that value was chosen, and moving back from 10%. And so you still may be saying, okay, I'm still not sure about meds, which is a number of patients who actually come and they see me in clinic. They're saying, Doc, I'm coming to see you because I don't want meds. And it's like, okay, well, let's still look. Let's look. We want to make sure we do the right thing. So after I calculate the risk, the next thing I want to know is, well, are there any other things that maybe I'm missing that pose an increased risk to you? And we call these risk enhancing factors. So these are things like, do you have a strong family history? Do you have a level of primary hypercholesterolemia where your values are so high, like I just mentioned, above 190? Do you have what we call metabolic syndrome, which is just a touch of increased obesity, just a touch of elevated blood pressure, just a touch of glucose intolerance that's there, that makes us now concerned? And we know with metabolic syndrome, you increase your risk for cardiovascular events. Or is your kidney function a bit sluggish based upon the way in which your kidneys are filtering? I always use the analogy, our calculation of kidney function, think of it like cheesecloth or like a tea bag. The more tea leaves you see in the cup, the less effective that filtering system is for the tea bags or the cheesecloth. And very similarly, we're measuring that inside your system. We're looking, do you have other inflammatory conditions like psoriasis, rheumatoid arthritis? If you're a female, did you go through premature menopause? I'll tell you, women, you have a superpower. The estrogen, the progesterone that you produce naturally, not synthetically, that's your superpower. But as we age, you lose that superpower, that lining, that force field, and it poses a level of risk that exposes you to us mere mortal men that we normally have. We look at other high risk ethnicities based upon genetics and based upon environment. We look as well as I mentioned, your biomarkers, and we're going to touch on these a bit more. Your C-reactive protein, lipoprotein A, ApoB, as I've mentioned, other features that are there. Once we identify this helps paint the picture about how aggressive we need to be in lowering that cholesterol, because guess what? Cholesterol matters, lipid matters. And this is the thought process. So the first thing out the gate, most docs want to prescribe, give you is medications. And why? They're saying, well, we want to give you meds to reduce your risk. And you say, well, okay, well, what? Well, the medications are all based typically off of our understanding of what we call pathophys and based upon the workings, a lot of times, of nutrition. But whether or not we're interacting at bile acids, remember I told you the cholesterol has gone to make bile acids. So is that going to help? We'll talk about that more. Is it from the standpoint of statins? Is it standpoint of ezetimibe? And these are different types of agents that are used that can target specific avenues, intestinal absorption, cholesterol production that's there. And so when we look overall, we see that there has been. I know folks may not love hearing this, and so I don't want you to think of use of medications as a scarlet letter, right? It just should not be your first line. It should your first line, depending upon your risk, should always be aggressive lifestyle intervention. But we always want to be grateful that we have avenues of resources if there is a need. And so there are studies that really have validated, and we have to weigh the risk versus benefits of the relationship between aggressively lowering our lipid profile with therapeutic intervention from statins and showing a reduction in major events. They've shown overall, when we look at graphs like this, we're looking at this vertical line that's there. And what we're trying to do is anything that's towards the right shows a benefit. Towards the left, it's questionable. And so multiple studies have shown a reduction in the risk with aggressive statins after a heart attack, right? And so looking in that range that's there, other studies have shown that there's been regression. So people say, you can't reverse coronary disease. Yes, you can. We don't believe Dean Ornish's evidence. We don't believe the work from Mount Abu, which showed that replicated the effects of it. We don't believe the anecdotal reports from Dr. Esselstyn, Dr. Furman, or even Dr. Batiste, what he says. Well, studies have validated that when we're able to drop the cholesterol levels down below 150 for total cholesterol, our LDL, low density lipoprotein, cholesterol and particle size, apolipoprotein B, down below 70, below 55, we're showing that there can be a halting of coronary artery disease progression. And in some instances, there can actually be the reversal and the regression of it. Now, some of you out there may still say, like, I'm still not quite sure about this, doc. And so I always want to bring you over. And so there's multiple avenues. This is one of my patients, not literally her face, but it represents her because she was wonderful, incredible. She sought me out, drove 50 miles in to see me, and she was an avid whole food plant-based eater. She did practice yoga, mindfulness, meditation. She, despite all this, her total cholesterol is 267. Her triglycerides, remember I told you, that's reflective a lot of times of the dietary intake, which I can tell, was 107. Her HDL, historically representing in terms of its ability and involvement with reverse cholesterol, moving the cholesterol out the tissues and so forth, out the coronary vessels, was 61. Her LDL, once again, that cholesterol, the calculated, was 185, still on the high side. And she was noted to have an elevated lipoprotein A, which we'll talk about more. And she did not want to take medications, which led her to seek me out. So as we did this, I went to the next level. I identified her family history. I calculated her risk, which was still low, but I recognized that her levels were very high from a risk enhancing perspective. So we then moved towards calcium score testing, right? So we did the coronary artery calcium scoring. And that was extremely important because that would tell us, is there any evidence that atherosclerosis is present in your heart or in your vasculature at all? And I'll tell you that the value of a calcium score, identifying patients at high risk of atherosclerotic events or de-risking them, trying to really identify which avenue. Is it something we have to do or not? And so when we know it's rapid, it doesn't cause a lot of radiation and so forth. It gives us the specific signs as the image of the hand is pointing to, the white flecks that are there in the calcification. It takes a very short period of time. There's even technology that is able to extract out your calcium score based on maybe prior imaging studies that you've had before. And so when we look at this, there was a large scale study that was done that showed that even in individuals who were deemed at having a risk level that was high, that necessitated statin therapy or aggressive intervention, many were found to have a calcium score that was 0. And when they did this, they were able, 45% in that arm were demonstrated to say, you don't know, you don't need to have it. And so we're seeing that 50% of statin candidates have a calcium score of 0. And their risk is less than treatment threshold, which means we don't need to, that your lifestyle that you're already doing is showing its evidence. So we know it's a complete package. We're always trying to identify the risk. And I know some of you say, well, I'm still not quite sure. I've heard so much about cholesterol that it's fake, it doesn't matter. And I see all these docs on TV that are saying, I'm not really quite sure about the cholesterol. And part of it is, there's been studies that have shown that approximately 40% of individuals with coronary heart disease, they have a total cholesterol level below 200, right? And so that means that they're still having heart attacks even though their cholesterol is low. Well, this gets us back to what we started at the beginning. There are many reasons why that standard lipid profile may underestimate your risk. We're always trying to identify your risk. And so inflammation is a major driver, right? I always tell everyone, if you've cooked at all in your life and you have the stove on and you turn around, you walk away, whatever inside that pot is the liquid's going to evaporate. And guess what's going to start to happen? It's going to overcook. It's going to burn. You're going to have all the features. That's inflammation in your body. It is slowly, if the fire is on low to medium, it's constantly there, inflaming, causing issues. And so there are markers. C reactive protein, high sensitivity C reactive protein, is a marker that gives us a sense of the level or the impact in terms of cardiovascular disease. And so what the studies have shown is that it's so correlative that high sensitivity C-reactive protein, it correlates with increased risk level. And so when you have a high sensitivity C-reactive protein and you have a high low density lipoprotein, we know that your likelihood of having events is high. But as you but as you have a low C-reactive protein and low density lipoprotein, the black line at the top, you have less likelihood of having events and your survival is improved. So it goes down exponentially. That's there. So it's very important. So in my patients, that's one of the tools I'll always measure. What's your C reactive protein? So if a person is like, Doc, I'm on a whole food plant-based diet, I have minimal this, I have minimal oil, I have all these other things that are there. I'm like, and I'll check their panel. We're checking high sensitivity C-reactive protein to get a sense of it. I'm checking apolipoprotein B. Why? Because I told you those are the police sirens. I don't care what the packaging of the vehicle is. If it's a motorcycle, if it's an SUV, if it's a Mustang, if it's a Dodge Charger, whatever type of car, I will be able to identify that car if it's a government police agency, right? Based upon the lights that are there. So this apolipoprotein B gives me that same sort of information. And it tells us that based on the levels, dose dependent, that it denotes an increased risk of heart attack and atherosclerotic vascular disease in men and women. And so we understand that it's very predictive, more so predictive than just looking at the cholesterol content. Because remember again, beach ball, it may have higher cholesterol content from the triglycerides, but not the cholesterol ester. Your small, dense golf balls, you won't get as much of that large triglycerides that are there, and it's not measuring the same, but it's more damaging. And so I may miss that. And so the lipoprotein helps me. Understanding that apolipoprotein is an accurate marker. Why? Because it helps these particles enter the arterial wall where they're trapped in larger cholesterol-rich particles and leads to the inflammation that happens. This is important. This is a study published out of Journal of American College of Cardiology. We look at lipoprotein A. This is a major one. And part of the reason why your docs may or may not be in tune with wanting to check this value is because historically we have not had good pharmaceutical intervention, nor has there been, in all truth, great robust data from lifestyle, from plant-rich nutrition, and reversing lipoprotein. There's been a few small studies that have shown that, and we'll talk about that a bit more. But for the most part, this is a marker. We see it more in ethnic groups. We see it more in women than men, but we see these high levels. They're associated with an increased progression of coronary plaque burden and the increased presence of low density non-calcified plaque. So what I'll tell you. So once again, using my own personal story, my sister, she came and she showed me her panel. Apolipoprotein looked great. Her total cholesterol looked good. All these values for her lipoprotein A was high. And I told her and I stressed her, let's drive your apolipoprotein down further. Let's drive your values down. I want you off of any refined carbohydrates. I want you off of animal proteins in this particular time that are saturated that may lead to increased low density lipoprotein particles that inside your bloodstream in order to decrease your inflammation, drive your C-reactive protein down, because that's what we can focus on. And by doing so, and so a lot of patients will come to me and they're like, okay, doc, I hear you. I'm still not sure about the meds. Can I take any supplements? So, okay, well, what are supplements? We understand these are taken in as dietary ingredients, and we know that they, once again, are like medications, that they're extracted from, in a reductionist model from the food itself to try and get the most active ingredient, right? That's the goal, to get the most active ingredient so it can have some therapeutic intervention. But there are several tools out there. And so I want to review some of them with you. So you probably have heard of red rice yeast. Now, the abbreviation actually is red yeast rice. So RYR is the abbreviation. And this one has historically been identified as having a very similar mechanism of action to your cholesterol-lowering medications, your lovastatin, your pravastatin, your simvastatin, your rosuvastatin, your Zocor, all these various agents working through what we call the HMG-CoA reductase. And so it inhibits that, which prevents the synthesis of cholesterol. And so it's a very weak one. It's not a weak in terms of compared to our higher intensity statins, but it does show some value. We understand that it can reduce your LDL levels between 15 to 30%. It's been shown to reduce your apolipoprotein B. It's also been shown to reduce your high sensitivity C-reactive protein, and which may lead to some of its anti-inflammatory effects. And so we understand that this, in general, as I just mentioned, is so beneficial at reducing cardiovascular events. So there's a wonderful review that was done inside the Journal of American College of Cardiology now about 3-4 years ago. And this review kind of highlighted just these variables that are there and showed some of the benefits looking at the value of red rice yeast. Now, the cons are is that there's no FDA oversight, right? So in terms of looking meticulously at how we can identify the precise amount of active ingredient in every pill, in every bottle, or if there's a wide variation, that's where there can be a level of concern that if this medication is taken in conjunction with other traditional medications, it may increase the risk of side effects too as well, most potentially in terms of the breakdown of the muscles called rhabdomyolysis. And so we have to be careful in terms of its use and may for sure discuss that with your providers. We have other agents like bergamot too as well, or other uh, nutraceuticals that are there. And it's been shown to improve lipid profiles, reduce total cholesterol, your low density lipoprotein, triglycerides while increasing HDL. And so there's been reviews showing reductions up to 40% in LDL and triglycerides with additional benefit inside those small, dense particles. But not only that, they actually showed some subtle reduction in what's called the carotid intimal medial thickness. So inside the one vessel inside your neck called the carotid artery, you have multiple layers. You have the intima, the media that are there, and the adventitia. And so the media increased thickness is reflective of that's where you have the deposition of atherosclerosis. And so when it thickens, or whether or not you're able to regress that, reverse it, suggests in terms of stalling and slowing down this process of atherosclerosis. So that's what that's in reference to. It also showed, though, that there were no significant adverse events in the majority of studies, right? So that suggests it might be favorable. But, we don't have structured randomized studies comparing individuals taking it versus those who are not and looking distinctly. There are a few, but not robust amounts. So overall, it's pretty useful. Once again, it does follow a similar pathway, this way in which your body will digest and resolve medications called the cytochrome P450 enzymes. And so that's important because if you impair that, if that enzyme gets basically too busy with bergamot, that means that other agents that you may be taking may increase your risk for adverse events. So it's so important to really discuss it with your pharmacist. And this is a note. Before just taking over-the-counter remedies, have a detailed discussion with your pharmacist, with your physician, if your physician may or may not be aware, to ensure that there are no adverse interactions between the medications you may have to take and supplements. Other one is niacin. Now, niacin, obviously, as we know, can lead to flushing, has benefits. And so, in theory, we thought niacin is going to be great, right? It's not a traditional pharmaceutical agent, the SPE3. It's effective on lipid profiles and inflammatory markers. It lowers your LDL-C, that LDL cholesterol, when added to statins, and it's going to decrease hepatic synthesis of triglycerides and the other cholesterol components. Valuable. It's going to reduce your C-reactive protein, your apolipoprotein B2 as well. I'll tell you, niacin is like that great movie that has all the perfect actors. It has the director, and you're like, this is going to be a great box office sale. But when we looked in terms of the outcomes, and put it to the test, we found that the actual outcomes in terms of what do we really care about, not just lowering in these markers of risk, we want to decrease the risk itself. I want to have less heart attacks, less heart failure, less death. And what they showed is that it didn't significantly reduce the cardiovascular events when added to statin therapy. And it found no real true benefit, which makes it why we don't typically recommend it in high level, right? So because it doesn't decrease death, it doesn't decrease cardiovascular events, but it has those side effects like the flushing and so forth that are there, it's not highly recommended. It's something that is a tool to be considered, but it's not one in which we strongly recommend. We look at AMLA, Indian gooseberry, another beneficial fruit, once again found in nature. And it found that 5 randomized trials basically showed that AMLA significantly reduced, once again, that inflammation, turned down that fire, blood sugar levels, your LDL cholesterol, total cholesterol, triglycerides, while increasing the good cholesterol, or historically thought of as good cholesterol. And so there are studies looking at a comparison of AMLA and simvastatin in patients with high cholesterol, and it was able to demonstrate a reduction in these values, which is beneficial. So once again, looking at how the mechanism of action, comparing that with the risk and the side effects, many of these agents have a very similar type of mechanism of action, working at inhibition of the HMG-CoA reductase, which is the pathway that we use for statin therapy as well. So next question I typically get after I go through all this with my patients is, well, what about the food? It's got to be the food, right, doc? Isn't the food? And I'm telling them, yeah, food, it adds to our whole sole goal is about maintaining our health. And one of the things I talk about oftentimes is that our health equals our resiliency divided by stress, right? You think about it, resiliency divided by stress. Sometimes we can't eliminate the stress in our lives, but we can always work on building the resiliency. This was the foundation of my book when I wrote about the book, in terms of trying to really identify what can we do to offset the stressors in life that are bound to come at us. Well, I will tell you, food can either add to your resiliency or it can add to your stress. And so one of the things that we identify is that about 25 to 75%, wide range of humans, that we absorb excessive amount of cholesterol from our diets, which is why in part you get this wide variation. And some patients will say, hey, I can eat anything on earth and my cholesterol levels are great. Others will say they eat a small amount of not great food, and their cholesterol levels rise from the the exogenous standpoint from their ingestion. And this may possibly explain the wide variation in some studies. And we look at things like eggs, right? So the effect of egg consumption, it's multifactorial. But we look at the effect of egg consumption on LDL cholesterol. It's been mixed. When we look at some studies, they report moderate increases in LDL cholesterol, approximately 1.9 milligrams per deciliter per 100 milligrams of dietary cholesterol. Others show no significant link in the cholesterol. And so part of this be accounted for based not solely just on the cholesterol content of eggs, but also from the standpoint of just the way in which this person is a hyperabsorber or not. We also look at C-reactive protein, another major issue, as I've talked about already, that there's not a great relationship between egg consumption and C-reactive protein. It becomes less clear. Meta-analysis, which means a large grouping of studies, basically showed that there are no significant effects of egg consumption on C-reactive protein levels. That makes it kind of, you start to question. But when it comes to apolipoprotein B, there is growing data that says that there is an impact. Now, we just talked about apolipoprotein B is the marker you really want to know, and it tells us that there may be a relationship. This is apart from trimethylamine oxide, the pathway in which, from animal protein ingestion, that there can be a triggering of atherosclerotic events. We're looking specifically at lipids. So not only that, also looking at the microbiome, which is part the trimethylamine oxide pathway and the L-carnitine. And so we have to understand our decision about consumption of some of these products. We need to look at the whole picture, not just reductionists, but understanding the impact, whether or not it's for cancer, if it's for cardiovascular events. Now, the other big area is saturated fat. Now, there are some out there who say they want to make frying tallow again, that animal fats are extremely beneficial for you, and that this is a preferential course. And we have to begin the process of separating out fake news from fact. And we have to understand that beef tallow, it's a solid fat. It's a whitish fat. It's basically rendered beef fat, right? And it's found in their organs and skin. And is primarily composed of what? Saturated fats. So you say, okay, well, what's the big deal about saturated fats? Well, it raises your low density level lipoprotein. In other words, your particle size, your particles that are there, which we understand, as we've identified, is a risk factor for future atherosclerotic cardiovascular events. So when we look at this process that can be complex, when you look at it from the exogenous, from eating these substances, that saturated fats, they raise your low density lipoprotein cholesterol by suppressing the activity of LDL receptors in the liver, right? And this reduces the clearance of LDL from the blood and promotes its production. So when we look at what is the impact of consumption of saturated fats, we want to minimize saturated fats, which is a unanimous recommendation. That is by American Heart Association, American College of Cardiology, and what the evidence in lifestyle medicine tells us as well. Recent study published just now looking at a comparison of essentially seed oils. It was a mixture. It did have olive oil, but various seed oils, which has been vilified in comparison to butter, a form of saturated fat. And it found that when you replace this, that you're going to cut your premature risk of death by nearly 17%. They examined over 200,000 individuals for over 30 years. And they found once again that the higher consumption when you replace these saturated fats with the plant-based oils, soybean, canola, olive oil, it was associated with a lower risk of cancer and cardiovascular disease. So we have to understand, what are we comparing it to? The study did not compare no oil to oil. It compared replacing, substituting out saturated fat for seed oil or plant oils and seeing it. Side note, many of the seed oils are associated and embedded with ultra processed foods. Ultra processed foods are highly palatable, and we understand, given not only the additives, the emulsifiers, the refined carbohydrates that are all triggering this disease process, that it's encapsulated. So it's difficult to tease out seed oils as a primary driver of adverse events when you look at the packaging of ultra processed foods. Another very interesting study that was published some time ago, looking at young and healthy, meaning no issues whatsoever. They said, let's put you on a low carb, high fat diet, and you continue your other standard diet. It wasn't necessarily a plant-based. And what they found is that you had an increased level of risk, of increased level of markers, apolipoprotein B, total cholesterol, low density lipoprotein cholesterol, uric acid, in this low carbohydrate, high fat diet, compared to the other group that had no change just after 3 weeks. Others say that was done really looking and teasing out the effects of high saturated fat diet on LDL particles with atherogenic dyslipidemia. This randomized. So what they did, LSF is low saturated fat, HSF is high saturated fat, and looking specifically at their total cholesterol, the delta means change. On the low saturated fat, they had a minus, means it reduced down to nearly 6, whereas the HSF went up, was increased by 11. And you saw this consistently. Your LDL-C down by nearly 9, up by nearly 17. Your non-HDL, another marker of the atherogenic particles, down by nearly 8, up by 13 in the high saturated fat diet group. Your apolipoprotein B down nearly 7, up by nearly 10 inside the high saturated fat. We're seeing a consistent theme in terms of the data that's there. We understand that when we look at a breakdown of our cholesterol, the large buoyant beach ball versus the small golf balls, we see a difference as it relates to what we were demonstrating in terms of the outcomes. I think it tells us, number one, It's never too late to change the direction in life that we're going in. And if we recognize the simple equation that our health equals resiliency over stress, we know we can impact that by our nutrition, right? And so understanding that our nutrition plays a role in building our resiliency or adding to our stress was the premise once again for selfish. And so when I look at selfish, spiritual, which means what is your purpose in life? What's your meaning that you're getting? And the practice of it, looking in terms of your breathing and meditation, mindfulness, the E for exercise, the L for love, for forgiveness and gratitude. The F, the central piece is F. And it stands for food, but also factual food. It stands for fiber-rich foods that are there. The I stands for intimacy of relationships. The S stands for sleep and rest, and the H stands for joy of life. And this is what let me develop what I called at that time the Cath Lab, Cooking Alternative to Health, where I volunteered my time to deliver cooking demonstrations to patients to really identify how the foods that you eat can add to your resiliency and fight disease in a similar mechanism that I implement inside the Cath Lab, that we can still regress vascular disease. We can halt the progression. We can still keep you from having future heart attacks. And that food can actually add to your resiliency. When we look at this everything, remember I described to you the line, that vertical line, and everything to the left of the line denotes in terms of regression. It's an improvement from baseline. To the right means it's a worsening of baseline. So we understand when you substitute saturated fatty acids for trans fats, which should not exist on Earth, all right, that is going to increase your risk. When you substitute saturated fatty acids for mono and polyunsaturated fatty acids, we see an immediate benefit. However, when you add in the refined carbohydrates, the standard American diet, right? Carbohydrates from that, we see a worsening. That's no surprise. But when we have carbs, that's what I want to tell you. Carbohydrates aren't bad for you. Garbage is bad for you. Garbage is garbage. And so the stuff that melts in your mouth, not in your hands, that leads to increased events, that is stuff that's made from refined carbohydrates where all the fiber is extracted, the water, and it maintains its shelf life. We see this multiple studies still telling us a very similar type scenario in terms of looking at the outcomes. Now, so overall, when we replace saturated fatty acids with polyunsaturated fatty acids, reduces occurrence of coronary heart disease by 19%. Each 5% greater intake of polyunsaturated fatty acids reduce coronary heart disease by 10% and decrease the LDL-C by about 10 milligrams per deciliter. So when we look overall in terms of the oil debate, which is there, and this is a part of it, great study done by Monica Agrawal, published in Science Circulation, that's their randomized crossover trial, which means they kind of had two separate groups, put them on a plan. They didn't know it was blinded. And then what they did was they crossed them over and they switched the diets to kind of see what would happen. They took adults, 5% cardiovascular disease risk. Remember, I talked about 5%, 7.5%, 10%. So they said 5% above, which means they had some level of risk that was there, and they followed what they called a high, which means only 4 tablespoons, right? So 4 tablespoons, that can go pretty quickly if you're frying, right? If you're making frying tallow again, that can go pretty high in other situations. Compare that to a low, less than 1 teaspoon per day. That means essentially none. And using low to high extra virgin olive oil, and they along with a whole food plant-based diet. So the common theme was let's make sure the nutrition is great. They gave them a 1 week washout, which means they didn't just start you one day and switch diets the next day. They had a washout period of time before switching over, and they both diets. Right. So it means that the core component of a whole food plant-based diet, it results in a decrease in your LDL-C, your total cholesterol, your apolipoprotein B, in glucose and high sensitivity C-reactive protein. So there's value in the whole food plant-based diet. But when they looked at the sequence of the diet of the oil, what they found is that the differences in the diet by diet order. So when you went to a low diet, low oil consumption, the delta change it reduced by nearly 12.7, right? Versus low to high, it increased by 15.8 in terms of the LDL-C that's there. And so we understand that there was an increase, and we looked at other metrics too as well. So it tells us every person is different and individual. And so if you're consuming oil, you have to what I call inspect what you expect. You have to look and see what is the impact on your own lifestyle. What are your numbers measuring out to be? But not just understanding that your lipid profile is imperfect. So you have to be aware to be able to ask your doc, not just your total cholesterol, not just your HDL, not just your triglycerides. What is my apolipoprotein? What's my C-reactive protein that's happening there that gives you a better reflection of the impact of your lifestyle? So one of the things that we would do additionally inside of our cooking classes, we would make certain meals like this one, overnight oats with chia and with flax and with berries and oatmeal and a few nuts of walnuts and so forth that were there. And then one of the things that we look at is, well, what are some of the ways that oatmeal can actually lower, right, your cholesterol? We understand that oatmeal is amazing. It actually binds to those bile acids. Remember, I told you that cholesterol goes into making bile acids. So because the oatmeal binds to the bile acids, it makes your body absorb more cholesterol to make bile acids. And that's where the value of the oatmeal comes into play. Now, I'm not talking about the instant oatmeal. I'm talking about the stuff that makes you chew a little bit, the steel cut, the regular oatmeal. It reduces cholesterol absorption and it enhances cholesterol excretion. That's powerful. And the studies really back it up that when you look at the core component, which is this oat beta glucan, it has a lowering effect on LDL cholesterol, non-HDL, and ApoB. And so these oat containing foods are extremely beneficial. Now we look at our berries. Now we know berries are rich in antioxidants and strong in antioxidant power, but not just that. We know that they enhance cholesterol excretion, they reduce the cholesterol absorption, they improve the lipid profile. So they're rich in what's called anthocyanins, right? And so anthocyanins are so important because they, once again, they promote that excretion of bile acids and the sterols, and it prevents that cholesterol from being reabsorbed in the intestines, and it forces the body to use more cholesterol once again to produce those bile acids. So we know as well the phenolic compounds in the berries, they actually work to help inhibit that absorption. So here's what they work at. They work at a site, the same site as Zetia, the Niemann, or ezetimibe, the Niemann pick-like one receptor, and it's responsible for cholesterol uptake, and that's where your berries work at. So that's where you're getting value. So when I tell you that there's power in your food, there's actually a pharmaceutical intervention from it. There is, and that's why when we look at studies, participants who consume fruits for 6 to 7 days per week have lower risk of high cholesterol, dyslipidemia, and high cholesterol compared to fruit consumption of 0 to 2 days. So it doesn't matter if you blend it, eat it though, preferably get it in season. That's, you get the full value that's there, and you're gonna have power. We look at seeds are so important in nuts, and I know there's so much debate historically over it. Now, truth be told, a moment of honesty, right? So I am beyond a shadow of a doubt, I'm a snackaholic, right? Like I'm a recovering sugaraholic. So I'm not that guy who can just have mounds of nuts and seeds there because I will eat way too many of them. But if you have raw and unsalted, all right, not chocolate covered, not buttered toffee or anything of that sort, and you measure out to add to your oatmeal, to add on top of your salad, there's value that's there. And so once again, they block cholesterol absorption, they improve those LDL cholesterol levels, and they enhance the excretion when we look overall. And that's where we start to see the studies reflect the same thing. 3 tablespoons is all you need. I'm not looking at more than that in terms of adding to weight loss, adding to the prevention of atherosclerotic events. We know too as well the almonds, excuse me, the walnuts, extremely important. I love walnuts because they're omegas. I love them because of what they provide in general. And we know that they can help reduce your total cholesterol values, your low density lipoprotein, your apolipoprotein B levels as well. So significant impact by having this. We understand that you're looking at your flaxseed and your chias too as well, that these omegas are extremely important in affecting the lipid profile, targeting once again the LDL and target and total cholesterol. Now we wouldn't stop there. We'd always make a couple of meals. So we'd also always do a bowl. I'm a big bowl advocate. I think it's such an easy way in which you can craft your dinner to adopt a healthful eating pattern. Is, I never forget meeting a patient in my office, and I start giving him all the business on transitioning his diet, talking about cutting and chopping and having wonderful stuff. And he said, looked at me, he said, Doc, I live in a small 500 square foot room, basically. I have, there's infestation of bugs. I don't have storage for all this. And it made me shift and transform my mindset immediately. And we moved over to saying, okay, let's get BPA free cans. Let's get bags that have beans in it that you can pop in the microwave. Let's get frozen vegetables. Let's get frozen rice or bowl in a bag rice. And you can make your own bowl that's there. And so that was the premise behind many of it. This bowl looking at a wild grain mixture of brown rice and black rice and so forth, red rice, the cruciferous vegetables, the mixture of the kale and the broccoli, and then your tofu too as well. And I'll tell you that when we look at soy tofu, the ways in which it lowers the cholesterol very similar. It's going to actually stimulate the LDL receptor activity. And so what this does is that in the liver, and this helps remove that bad cholesterol from the bloodstream. It's going to block that cholesterol absorption. Once again, it's going to inhibit the absorption of cholesterol and bile acids in the intestines. And this once again causes the body to remove that cholesterol to create more. And then basically it's going to be a subtraction by addition. As you start adding in the tofu and the components that are there, you start to move out some of the saturated fats from the diet too as well. So there's power that's here. And the studies have demonstrated this, that having an amount over 6 weeks, it decreased your LDL by 4.7 milligrams per deciliter, that we're seeing all these these benefits to total cholesterol as well as to the other non-HDL components. I'm a big proponent of dark green leafy vegetables for many reasons. Dietary nitrates, the fiber that's there, the vitamin K2 that can be from some of your fermented vegetables as well. That all these things are important and very similar. So I'm becoming a broken record. It binds to bile acids and promotes the cholesterol excretion. It reduces the oxidized cholesterol, right? And so your greens like spinach and kale, it contains the lutein and other antioxidants. And I'll tell you what they do is they prevent LDL cholesterol from becoming oxidized. That's important. That's the process of inflammation in there because the oxidized LDL is more likely to stick to the arterial walls and lead to plaque buildup. So reducing that oxidation, it helps prevent and protect against disease. That's why there's so many studies that are increasingly coming out regarding the power of dark green leafy vegetables too as well. So this is one of the things. And so we understand the soluble fiber content. It's been shown to decrease your LDL. This is extremely important. I mentioned the dietary fibers as well. This is looking overall, the overall trends. We see a decrease in total atherosclerotic cardiovascular disease, ischemic stroke, peripheral arterial disease, as well as with the ischemic heart disease based upon the intake of these vitamin K rich vegetables, which is extremely important. And so these have also been shown to decrease in terms of hospitalizations and subtypes of hospitalizations like ischemic heart disease, heart failure, and stroke. So important. We want to steam the vegetables, right? That's going to improve its in vitro bile acid binding. Remember the bile acids, once again, the body uses cholesterol to create bile acids. So if I can bind these and remove it, that's why I get a big box. I wish I could farm. I wish I could go. I had time for doing that. I don't. So I order a box of greens every 2 weeks that my near 90-year-old mother will make up for me. I know, don't be jealous. She takes care of me. I don't live with my mom. My mom lives with me, by the way. And so she will cook up the collards and the mustards and the dandelions that are there. I make sure I'm getting in as much bile acid binding power as I can. These things are extremely important in terms of our progression, trying to prevent disease, the anti-inflammatory benefits for the aortic tissue, as I mentioned, in terms of the atherosclerosis being embedded. You know, there's nothing wrong with the grains, and I understand about arsenic. I understand about cleaning and the sourcing of it, but we understand the power just in general in terms of some of our colored fiber-rich whole grains. And so we understand these as well. Reduce cholesterol absorption, promote LDL receptor activity, as I mentioned, and promote the antioxidants to prevent that LDL oxidation. Once again, similar type scenario as the others, and so especially inside your pre-germinated brown rice, it shows a benefit not only in fasting glucose but also on total cholesterol. There's power that's there. Beans, extremely important, right? All of them, black, red, brown, white beans, they're all good, similar fashion. Binding of the bile acids, promoting cholesterol absorption, decreasing cholesterol synthesis. These beans are the superfood. I don't care what anyone out there says. Yeah, you want to rinse them off. Yes, you want to cook them. We understand that it can actually be beneficial for your cholesterol values. Reducing your low density lipoprotein is going to be beneficial for your overall health. There are multiple trials out there that are telling us the similar type scenario. So let's put all this together, right? I mean, like any meal, you have to put all of it together. What's our meal plan? We need a portfolio, right? Just like you're going to diversify. I think that's one of the key things. Right now, there can be quite a tumultuous market that happens periodically. And if you're diversified, you're protected. And so, very similarly, your diet needs to be diversified. You need a portfolio of nutrients. And so, wonderful work done by David Jenkins in Canada, who looked at the use of a lot of the soy and the whole grain and fiber rich foods. And he found that use of a dietary portfolio, it was comparable to once again to the use of statin therapy and lowering your low density lipoprotein cholesterol. And once again, understood. Particles are more important. Apolipoprotein B is more important. Majority of the studies are based upon the standard profiles that are available and showed still a benefit during the 6 months of follow-up. He not only demonstrated that, he actually was able to demonstrate, in this slide may be hard for you to see, but apolipoprotein B diminish. He showed C-reactive protein markers of inflammation diminish. He showed outcomes that the blood pressure diminish. And so this is extremely important when you're looking not only at the markers of risk, but you're looking at the outcomes of risk that are diminished. Great work done by my colleague and friend, Dr. Baxter Montgomery, in conjunction with a medical student, demonstrating that an aggressive approach going essentially raw over to small amount, essentially eliminating all processed foods, juicing to raw, you're able to reduce your risk. Lipoprotein A, remember the one I said we don't have great therapy for as of yet? There are things in the pipeline. Apolipoprotein B, your LDL particles, the atherogenic LDL particles, all these aspects were able to be demonstrated to be reduced. This was published back in 2018. Others say showing us that when we transition over from eating any and everything over to a plant predominant diet that is of the earth, a whole food plant rich diet, we decrease the inflammation, we turn down the fire inside of our bodies that are there, and we show a benefit not only on your LDL-C, but your non-HDL, which is another measure of the markers of inflammation, as well as looking at the apolipoprotein B. This was was published in the Journal of American Heart Association back in 2017. Looked at this very study. So we know overall, when we look at comparison of diets, whether Mediterranean portfolio, the DASH, compared to statins, we see a reduction is indeed possible in your low density lipoprotein, your triglycerides, and the HDL is about neutral. That's there. So we know that there's benefits that are there across the board. We understand that the adherence can vary. And so what's interesting is that the published data once reports that the adherence to statins is high, but I will tell you clinically, the adherence to statins is not high. That the adherence to medications and recommendations are not high, and it's on par with the recommendations for dietary interventions. I will give you a side note before I get to the final summation in terms of a patient story. I'm gonna give you another patient story. It's a wonderful patient I met, truck driver, had a major heart attack, stent place, had recurrent symptoms, and I convinced him to really adopt and adhere to a whole food plant-based diet. He made incredible transformations. He did. His wife supported him, was making everything from scratch. He was doing so well, I almost didn't need to see him about once a year. We got lost to follow up, and I saw him subsequently, and he had gone through a multitude of tragedies. We had taken him off medications at that time because he was doing so well, and his numbers were about the threshold of what I wanted with medications. And this is important for you to understand. He failed to follow up. He had the death of his son. He had the loss of a job, and his weight had rebounded. His numbers were through the roof high, and he had zero protection in terms of medication, irrespective, once again, the risk versus benefits. And so it's so important, irrespective, that we have to maintain our health as a priority. The stressors in life are going to come. We have to look at the resiliency, and part of the resiliency is knowledge. It's knowledge of understanding as a whole. And so I felt bad for him and about really what's my approach in terms of making sure that individuals have a level of accountability for that risk is so important. We look back at my patient who chose to go down a combined approach. He did undertake the appropriate needs because he was hospitalized with a heart attack at that time. He underwent a form of revascularization. I always analogize that sometimes when the tire is flat, you have to change the tire if it's blown out. You know, if there's a nail in it, I take the nail out, but I need to teach you not to drive over nails. I need to teach you not to drive over spikes. And that's what we did. And so it was amazing, his transformation. As we started looking back through in terms of his cholesterol profile began to drop down pre and post, and noting that his values dropped essentially below 160. In this one, it actually dropped below 150 later on. His triglycerides, remember I told you a reflection of the dietary quality, dropped to 78. That tells you when you look in the 400s down to that, you look to as well as his low density lipoprotein as high as in the 200s, but now dropped into the 70s. That's power that's there. When we start looking at all of these components that are there, that it is indeed possible. Everyone's not the same, which means you may need to require medications. But I will tell you, there is so much that you can do from a lifestyle intervention standpoint, from the foods that you choose to eat, because as I tried to demonstrate today, the food has power that's there. So what are my top 5 take-home points I need you to know? I need you, number 1, to know your numbers. Number 2, ask to calculate, what is my risk? Right? The atherosclerotic cardiovascular disease risk calculator. Download it yourself, ask your doctor, ask your provider to do it too as well. If indicated, ask to reassess the risk, meaning, do I need a calcium score? Is there something else? Is there additional testing modalities that can help me figure out whether or not how aggressive I need to be? I need you to decide what's your level of impact. So even inside the oil study, I will tell you, I tell individuals, just like when I prescribe medications, there are some individuals I may have to start them slow and raise the dosage up slowly. Some individuals I can come out the gate and I give them the max dose. It's the same as with nutrition. Some individuals are able to adopt and adhere to a whole food, plant-based diet, absent of animal proteins, absent of ultra processed foods immediately and not fall back. Others, we have to begin to taper them up slowly and increase to get to the therapeutic intervention. Continually along that journey, you have to do what? That's number 5. Inspect what you expect. I'm expecting my numbers to come down low, that my risk is going to normalize or go low. I expect my symptoms are going to improve. My markers of X, Y, and Z are going to improve. If you are not seeing those numbers of what your ultimate goal is, then you have to have an intimate conversation with your provider to ensure that you're receiving the total care that you need that allows you to do what? Decrease your risk, preserve your resources, which is your health and your health span. And that's what I have for you today. I want you to encourage everyone here to go ahead and get selfish, primarily just so you can lower your risk, right? The risk is never going to be zero, but if we can get that risk as low as possible, that's what gives us the opportunity to live a life of purpose, right? And that's really solely our goal, is living a life of purpose. I appreciate everyone's time and attention, and we'll get at any questions if anyone has any.
Thank you so much, Doctor. Just real quickly, before we go into Q&A, can you tell everybody how they would get in touch with you if they wanted to follow your work?
Yeah.
You?
Thank you for that. Yeah, so the easiest way is, there's a couple of different ways. Social media, it's Healthy Heart Doc on Instagram. There's also, I'm on YouTube. I'm on many podcasts and interviews on YouTube too as well, and I put out content there. But most importantly, drbatiste.com, DRBATISTE.com allows you to kind of get to the blogs, send over messages too as well. I don't provide direct medical advice via those avenues, but that's the best way to get in touch with me.
Great, thank you. So hopping right into the Q&A. So you give a very in-depth look at cholesterol and the things that go around cholesterol. Why do so many people, including doctors, get the cholesterol story wrong?
Yeah, to be honest with you, I think that it's complicated. It's like everything else in life in terms of how much time is invested in training to really understand it, right? I think that's one of the avenues. And understanding that it's very complex, but not just that, but staying abreast of it. And so I think what's happened is that we've gotten caught up in terms of soul values and saying, well, they don't quite represent. So we throw the baby out with the bathwater. And that's problematic. But we understand it as one complete package that this is a process of inflammation and there are ingredients to this cholesterol story that all matter in the long and short term.
So during this conference, we've heard from a lot of different medical professionals who have looked at the literature. They have their clients, their patients, and they have seen the results of their recommendations with regard to the patient's health. And yet we so often get diametrically opposed opinions. The last speaker was Dr. Pam Popper, and she recommended that if you are in great health, if you have no pains or no indications that should drive you to the doctor, she does not recommend just blindly going in and getting your blood work done just because they will find something. But and that something can take on its own pathology, if you will, where it wouldn't have had they not, looked in to see if they can find something wrong with you. Why is there so much diametrically opposed thoughts on this stuff? And everyone has the research behind them. Everyone can point to their studies, and yet, everyone has their patients to prove it, and yet they come to such drastically different conclusions. And it's just really frustrating because, the people who come to this conference and people in general, they're searching for the truth. People are sitting here for hours a day trying to figure this out. And as lay people, and even the medical professionals, no one can seem to make heads or tails out of it.
Yeah, no, that's a great point. And I think one thing is the fact that we understand our knowledge changes, it shifts. So if we look at just the past 100 years, our knowledge has shifted. If we look at 75 years ago, we weren't able to do the things we can do now. There are people who have passed away and did pass away that could have received life-saving treatment and therapy. So our knowledge shifts. I personally, and this is, I'll speak to you from a personal perspective. So there's some things I don't want to know. I don't want to know my genetic testing. I say I'm going to worry about something I can't do anything about.
Mm-hmm.
But there are things that we can do things about. And so I think that that's where I say the question is knowledge is power across the board. And so understanding and knowing what questions to ask are appropriate. I do believe that a lot of times individuals go into provider's office. The construct of healthcare in the United States is one in which we move patients through at astronomical speeds, like a factory belt. And our sole goal, what we're doing is we're getting through in such a limited time of 10 minutes to 15 minutes. We're giving you prescription after prescription after prescription, and we don't take time to have a discussion. That's really what it's about, is understanding what is my risk? What's my risk? Now I try and determine, okay, what's right for me? What have I tried? What have I not tried? What am I willing to do? What am I not willing to do? What do I want? What am I willing to do to get what I want? What won't I do to get what I want? That's important information. So solely saying, just put your money inside the stock market and don't look because it's going to cost too much. Everyone's going to give you just conflicting advice. That's not right either. You have to either find a trusted individual, recognizing that is able to explain the information to you where it makes sense, that they validate what you're saying, and that communication is so imperative. But we don't say that in the other realm. We don't say, well, I don't want to know what's going on in my car. I'm not going to take it in to get a test to get it checked out. I don't. I'm not gonna. I'm gonna pay attention. I'm gonna turn off the oil indicator. I'm gonna turn off the gas indicator or the battery life. I'm just gonna kind of roll with it. We don't do that. Why should we treat our bodies any differently? Especially for the number one killer that's out there, which is cardiovascular disease, right? And cancer. So I am a firm believer. Now, what you do with that data, that information, I don't believe it should be one size fits all. And that's what I disagree with. But to be honest with you, that is on both sides of the coin. I don't believe that some individuals who may benefit from traditional therapy medications should say, no, I will never touch it. And I'm only going to go this route. And I don't believe that everyone should be like, no, just give me the pills and I want to eat whatever I want. I think those are both extremes that should never happen.
I mean, even with and I don't mean to pick on you on this, it's just
No,
like
please.
the juxtaposition of, Pine Popper versus what you're saying is very interesting, kind of highlights some of the challenges. So even the stock market analogy, a lot of people will say, don't look at your stock portfolio regularly. because you want to look at it over time. And if you look at it regularly and you make changes regularly, you're going to make mistakes. So even in that analogy, it's like don't look at it unless there's some sort of problem that causes you to look at it, right?
So no, we're on the same page. So I'm not saying that you check your cholesterol every month or every
Right.
6 months. I'm saying should you check it? Should you check it when you're at age 40 and then check it again maybe at age 45 and periodically? Yeah, I do think you should do that. I do think you should, what are just the same way you check your bank account, right? So I mean it's important, but what's the benefit in waiting until you're hit with symptoms? Because here's the thing. Let me ask you a question. When you're
Yeah.
boiling a pot of water, at what point does it become scalding that it can burn you? Is it once it's bubbling, you see so much steam, or does that happen potentially before that point?
I've never tested, but I'll assume it happens before.
It happens before, right? So we don't need to wait for the symptoms to bubble against. We understand that we're constantly in this warfare against wellness versus illness. And many of us are not perfect, right? There's some on this, some of your, I'm not perfect. I see disease all the time. I'm not perfect in terms of everything that I eat all the time and so forth. I try to be. I try to be as intentional as possible. And compared to the average person and maybe everyone on your group, you might say, well, no, you are. No, no, I'm not. Right. And the question is, what's perfect for my body constitution? I only know that if I'm inspecting what I'm seeing in terms of the outcomes and the numbers. And I've seen it time and time again in terms of disease process that's that peaks its head up, and you can't always offset that. But that knowledge gives you the potential to say, okay, I need to tweak certain things. I need to take it to another level. Maybe for me, a cheat day isn't okay. Maybe for me, a bite of this isn't okay. Maybe for me, that plant-based burger and fries is not okay. That I have to be very strict in terms of what my approach is. And so that's as a practicing medical physician, interventional cardiologist that sees folks come in. Typically, I'm skewed. You go to a pizza shop, you get pizza. You go see an interventional cardiologist, you're seeing people on life's death step, right? Heart attacks, heart failure, valve replacement. So I see it, I'm skewed. But the fact that I see people who are young and healthy, I saw this 49-year-old physician, and he said, oh, yeah, they told me about, came in with a heart attack. I see another physician who was doing what he was doing and not checking and so forth, and just about to retire, has sequential heart attacks. Put him on and inspect his values. Now he's knowledgeable. Now he's gone in, he's dropped his apolipoprotein B, he's dropped his LDL cholesterol, and he's transformed his nutrition, and we're tailoring it accordingly. What if we could have gone back in time and actually done that ahead of time so he
Right.
could see it?
And just to clarify, Pam Popper's point was you should be eating healthy, you should be exercising, getting proper sleep, mitigating stress, all those types of things. And you generally know when you're not doing that, or you can look in the mirror basically, and she would say, take off your clothes, look in the mirror, and you kind of have an idea of what kind of shape you're in. So the tests are really kind of medicalizing stuff that you kind of already know, and the general results are, or the general actions necessary are to actually take care of yourself, as you basically would say. And she's aligned in the same way. But to move on to the next point, you talked about cooked foods, or steaming certain foods to bind
Bile
bile.
acid.
I'm sorry, which kind of
Bile acids. So these were the green leafy
right,
vegetables.
green leafy vegetables. So now there's also like the raw is better
Mhm.
than cooked type of conversation. Can you speak to that? Because it's just, and again, I don't mean to pick on you whatsoever.
No, they're not. No, this is
Yeah.
great.
Okay.
I think part of, well, first I'm gonna start here is that the vast majority of people, and this is where I generally, just speaking completely honest with you in terms of like um lifestyle, and those who adhere to it and they support it and they lecture, is that it can almost seem unreachable, and we leave like the haves and the have-nots, and there's so many people out there. The vast majority of Americans are just eating burgers and fries and pizza every day, and sometimes we get so caught up in minutia over raw versus cooked. And the reality of it is that it's the processed crap that's out there that's
Mhm.
really killing everyone. And so for those who are tuning in who are like, whoa, really? I mean, you're vilifying raw versus steamed. That's not the case whatsoever. But when we want to maintain the nutritional fortitude of the vegetables as much as possible. And part of that, you're absolutely correct. You're going to get the vast majority from raw and from lightly steamed. But when you overcook vegetables, and you take out their lymph, you take out all the nutrients are absorbed out. Yeah, that's not, you're killing, you want it as close to nature as possible. But sometimes the chewing process, mastication, that helps break it up and it releases the isothiocyanates and it helps release the dietary nitrates and we look from bile acid component. And so looking at different variables that when you chop and that you're releasing chemicals that are there that can be beneficial, whether or not it's garlic or it's the onions and the allium family. And so I don't believe that there is the one, we're never going to have any randomized trials that are looking at this. We're probably not going to have any population-based trials that are looking at this that to any validity. So it's going to be primarily anecdotal. And because I want to reach not the choir, no offense, I want to reach the people who are outside who can't hear the music. That's what I'm trying to reach. The choir, whether or not I'm singing exactly precisely in tune or not, that's a whole separate thing. I
Mhm.
want to reach the folks who are like, I don't know about this. I'm a naysayer. I don't quite believe it. That's who I'm trying to reach and convince that there's a better way and a better way to achieve health and maintain your meaning and purpose.
Great, thank you. So on statins, we had Dr. John Abramson do a talk on statins. Are you familiar with his work at all?
No, I'm not.
So he's a Harvard Medical School professor, retired, and he wrote a couple of books. One's called Dosed America, and the other one's called Sickening. And his expertise is in public policy and how the pharmaceutical companies have basically taken over the peer-reviewed journals, where they basically fund them at a minimum over, 60% of their funding comes from reprints alone. So what they say gets into the peer-reviewed journals and a whole bunch of other things. And he had a whole talk on statins, and he talked about the number of people within various cohorts that needed to take the statins for a number of years for them to be effective. So
Number two, the treat.
I'm sorry, your number, yeah, right. The number of people that needed to be treated for them to be effective and to stave off a single non-fatal cardiac event. And these numbers were astronomical. They were, some of them were, in the hundreds. Some of the populations that statins are being recommended for, and even in people who had already had a heart attack. I think it was 1 in 33 people would need to take a statin for 5 years. Sorry. So 33 people would need to take a statin for 5 years in order to save off one cardiac event. So how effective are the statins given those numbers? And what do you think about the populations that are like they keep on lowering the populations that are able to or suggested to take these drugs?
Yeah, so I think one is I don't disagree with the premise behind what he's saying at all. I do think that we are too drug oriented in terms of our education, our research, and our care of patients just in general. I think the second thing is I think although we say it with our mouths and with written of lifestyle is the number one class one indication, it's the first line that's there. There's nothing that follows in suit afterwards. There's nothing that follows and dovetails out into clinical practice or that's reimbursed for that. And so it's minimized to a tremendous degree. And that's extremely problematic. In terms of the numbers, we know that the vast majority of people who are going to glean the benefit are those who've had an initial event, have had an event, more so than those for what we call primary prevention. Primary prevention is I'm saying I take someone and I don't want you to ever have an event. So can I give you a therapy that's going to prevent you from ever having anything ever? That's harder to really to hone that down, right? And that's why you need a larger number of individuals in order to kind of show a benefit at all. But when you look at individuals who've succumbed to a heart attack or heart failure or stroke, we recognize that every year the American Heart Association puts out statistics on the heart attack diagnoses, and roughly about a third of that volume is from a second, third, or fourth event. So we know that 30 plus percent of individuals every single year are having a second, third event. That does not include those who are having to go back for a second and third stent or bypass surgery electively. And so when we look at this churning of disease that we have without stopping it. I think the problem is we're not addressing nutrition early on, and we're not addressing lifestyle early on, and that we have a system that we tell people make a better choice. But that better choice, when you're surrounded by an environment that's encased with deleterious foods, and this includes in hospitals, many instances, that when you're brought in burgers and fries to celebrate a particular quality metric, you're given every celebration, you see the food that comes out after a procedure. That's problematic. That's tremendously problematic, and we're flaming the fuels that are there. So I don't disagree, but going back to your original question in terms of the numbers, a number like 33 individuals or 100, I'll be honest, is not very large in the grand scheme of the care that we look at certain things. So even like we look at what's the average cost of therapy to show a benefit that's cost savings. You look at things like $100,000. That's like our baseline threshold. There's certain numbers when we look at a comparison between nutrition and we look at medications or procedures. And I will tell you, nutrition beats everything. That cardiac rehab, it beats out all of the statins, all the aspirin, all the beta blockers, all of them in the number needed to treat. The smallest number, the smaller the number means the more potent it is when you look at number needed to treat. The larger the number is, it means it's less potent. That's what it means. And so I always use the analogy for even inside of medical settings, I think of it like those old sugary substances you would mix inside of a water, right? Kool-Aid or whatever it is. If you said you put in a small scoop of it and you're like, oh, it's not sweet, you have to put more and more and more because it's not as potent. When
Right.
very, very intense, you put a small amount, you're like, oh, that's enough. That's so the smaller the amount is, the more potent that therapeutic intervention is. And we know that cardiac rehab for prevention of recurrent events. Why? Because you're looking at mind, body, soul. You're looking at stress reduction. You're looking at exercise. You're looking at nutrition in an ideal situation, which is why the programs Pritikin and Ornish have shown and demonstrated a tremendous benefit, and even to the level of Medicare reimbursement as it relates to it.
So, and I just want to get a clarification on something that you were talking about. You were talking about statins, and then you mentioned about, and you were also talking about lifestyle changes, and then you're talking about reversal of heart disease. And I wasn't sure if you were saying that. I know like certain lifestyles, as Dean Ornish has shown, and Predican has shown, and Esselstyn can reverse heart disease. Were you also saying that statins can reverse heart disease, or just
Stat- yeah, no, actually, to be honest with you, yes, statins have been shown to lead to coronary plaque regression.
okay?
So, and so that's an important point I bring out to healthcare providers on a regular basis, because healthcare providers, my own colleagues, I'm lecturing to them actually after I finish here. I'm going to lecture to them on plant-based nutrition and cardiac rehab in just a few moments. And I will tell you, many will tell their patients after I talk with them, that's not possible. It's impossible to reverse coronary disease. So I first speak to them inside a paradigm that they're able to understand, which is medications. And I'll
Mhm.
demonstrate to them that there are studies, if you go back to the early studies on cholesterol lowering medications, that it would have the ability to regress coronary cardiovascular disease. We've been able to image this when we put ultrasound probes down the arteries. We can measure the actual amount of atheroma that's there and shown a regression. That's been demonstrated there, but it's also been demonstrated with lifestyle. The point of that is that you can achieve this by dropping your numbers down. But guess what? You have to inspect what you expect. You're going to have to still see, do I need to up the ante? Right? Do I have to increase my level of anti-inflammatory foods? Do I have to diversify the foods that I eat? Most of us eat in ruts. Do I need to have more than just kale? Do I need to have some beets? Do I need to have radishes? Do I need to have celery? Do I need to have onions and red onions and yellow onions and go down the road in order to improve my profile that's there? And that's really what I'm speaking to when I'm talking about trying to just make sure we understand, right? And we're not otherwise, what I've also seen is I've seen individuals who've done it and they're like, I don't understand why I'm still having this problem now, doc. I thought I did everything right. Well, I talked to them about, well, okay, what about the plant-based ice creams and the desserts? What about the stress and the lack of sleep? Again, 4 or 5 hours of sleep. What about the lack of movement? What about all these different components that are so important to you on a regular basis that you've eliminated from your diet or your lifestyle?
And did you have the study that showed the regression of heart disease from statins? Was that on the slide?
I did not include that. I'll send that to you though.
Yeah, if you could, I'm going to be doing a panel with Cole Esselstyn and T. Colin Campbell, and I
Hmm.
want to raise that with them. So
And, and granted, it's very minimal amount. So when we understand that just from the physics of coronary vascular disease in terms of the amount of regression, in terms of improvement of the flow. And I tell everyone, here's what I'm gonna say about that. Lastly, and this is what I tell patients. My goal is, once again, you have to always understand what question you're being asked. And my ultimate question is, I want to prevent heart attacks and I want to alleviate symptoms. In order to do that, I need to stabilize the endothelium. That's my first goal. If I stabilize the endothelium and lead to just marginal amounts of regression while improving the collateral flow, I've achieved my goal, right? And so we understand that that's why a whole food plant-based lifestyle is so imperative because it does just that. It stabilizes the endothelium, that lining of the vessel. It regresses some of the soft plaque that's there and prevents the eruption that's there. I don't need it to be go to have the plaque go from 40 to 10 or from 50 to 20. I need that to be stable. I could care less about what it looks like. I care more about the symptoms and the constituency of that plaque. If that normalizes and stabilizes, that's powerful. That's powerful. And that's what our goal is.
so you talked about the calcium score. What does the calcium actually mean? Like, at what point of the disease progression does calcium occur?
Yeah, so I mean, calcium is a reflection. So you have atherosclerosis and you have arterial sclerosis. So arterial sclerosis is more of like the hardening of the vessel. And that's where you start to have the calcium deposit that begins to happen. It is one of the earlier features of the atherosclerotic process too as well. And so it was so interesting is that everyone thinks of the narrowing of the vessel. It actually occurs outward too as well first. And that outward progression of the atherosclerosis is the part that's harmful. And then that cap becomes calcified before it starts to narrow inward and restrict the blood flow. So when I'm doing the invasive procedures and we were to place a probe, that ultrasound probe, we may see the vessel really is like a 7 millimeter vessel. And you're like, whoa, it's ectatic, it's gotten out, but the area, and we'll see lots of plaquing that's there, which means it's prone to having an area erupt and lead to a heart attack, but yet it's not obstructive in terms of disease. So the reason why you'll hear people oftentimes saying, you know what, the doc told me everything was okay. Well, most heart attacks don't happen from areas of narrowing of 70, 80, 90%. Most heart attacks happen from areas of 10, 20, 30, 40, 50%, what the studies have told us. And so stabilizing that is so imperative. So that's why the calcification is one of the earliest markers, which is why the calcium screening, calcium artery calcification score is so imperative that tells us, listen, your body is already taking hits as a result of what's going on inside you. If you want to stick your head in the sand, like I mentioned, my cousin, and am watching her eat, and she watched me eat this weekend. I just, I'm concerned about her risk level that's there. And so for someone like that, I think it's so imperative to see the numbers, but to also see the manifestation of the disease that hopefully can get them moving in the right direction because you feel fine
So
until
what about in the context of somebody who went whole food plant-based a number of years ago, and maybe they had a poor diet beforehand, so they had active heart disease, they
yes,
went whole food plant-based, they had the calcification, but that's really more of a vestige of the previous level of heart disease
yes.
and not necessarily a good indication. This is what I'm trying to put this in a question without making it into a
No, I
statement.
understand.
It's an indication of where they have been, not with where they are now.
No, that's once again why I mentioned about the total package, understanding everything. So if I'm looking at my C-reactive protein, and as I showed you in that last slide where the individual's numbers declined, and I demonstrate that, hey, listen, my ApoB has dropped, my C-reactive protein has dropped, my total cholesterol has dropped, my triglycerides are reflective of the quality of food I'm eating that's there. I'm doing well. I'm not having symptoms. Do I think this is where Pam Popper and I completely 100% agree? And I have patients ask me this all the time. Doc, when do I need to come back for an invasive procedure? I'm like, you don't ever, never. I said, you don't need to come back in. That risk is too high. There's no point in doing it. you feel fine, your numbers are good, we've lowered your risk. If the numbers are high and it tells us the risk is still there, now we have to see, is there anything else that you can do from a lifestyle, or what are the pros and cons, so the risk versus benefits of considering other therapies? And that's my whole point, not to vilify or to endorse the use of pharmaceutical agents, but to put them in their proper place. Let's try and exhaust, let's figure out what you want as an individual, what you're willing to do, what you won't do. Trust me, I've had individuals, I'll pitch them. I'm doing a hard sell for them to adopt a whole food plant-based diet, how we could avoid everything. And they look at me and say, Doc, I know I'm not going to do it. I want to, but I'm not going to do it. I was like, I'll give you every support that you need. I'll get you set up. And they're like, I'm not going to do it. I'll say, okay. Oh, okay. In that moment. And I recognize everyone won't be receptive. And it's not that they disbelieve me, but they were recognizing what they were willing to do to get what they wanted and what they wouldn't do to get what they wanted. And that's so important to understand in the whole process of kind of on an individual basis.
Do these patients, when they have serious heart disease, and the statins can only do so much if you're eating a bad diet. I mean, do they have the understanding that they're basically saying, I'd rather die than eat vegetables? Do they have that cognition?
I think many people out there believe it's like something that they can't escape, that this is just what happens as I get older, and that it would surprise you how many people are, one, unaware of the power of lifestyle and plant-based nutrition, and two, who believe this is just a part of aging. It's just what's going to happen. And that's problematic. And so when we look overall, I really try and let them know that there is the power to reverse it. And here's the biggest issue. Because our procedures have become so simple, when I do a procedure, the person walks, oh, it wasn't bad at all, doc. It feels like I just had an IV or my blood drawn. They have no idea of the peril that they were in for the moment that they were in. They walk away, they feel fine. It's like, I'll just come back in for a tune-up.
Right.
And so as technology and skill has improved to really take care of the blown out tires, it's not meant to go ahead and take care of the leaky tire and let's transform things. It's to take care of the blown out tire, but we're using it we're using it now in the wrong context many times. So when I get called in the middle of the night and there's someone who's having a massive heart attack, that's not my time to say I'm gonna feed you a kale salad. Right? That's not my time. But for the patient who's walking in and their doc is just seeing them in electively and they feel pretty good, maybe having sporadic, I'm having a heart-to-heart conversation with them about their transformation and what needs to happen. And I'm grateful that I've been able to make an impact in some patients who are not even mine in terms of adopting it. But the numbers aren't, percentages aren't high. I'm literally proverbially fishing every time I see patients inside the cath lab. I'm trying to get them to stick to this, and then I release them back out there, and it's a toss up. It's a toss up.
Of the patients that say, okay, I'm going to give it a shot, and then do it and see meaningful results, weight loss, their numbers go right, what percentage of them stick to the diet?
Yeah, it's hard. It's hard. I've seen, as I mentioned, I gave an example of a guy who had so much tragedy in his life, loss of a child, loss of others that led him to kind of going backwards in terms of things. But I've seen many others. I'm typically told sometimes patients are referred for an angiogram even though they don't have symptoms because they had prior history, and sometimes there are patients that have adopted what I've told them to do, and they'll tell all the staff. And the staff quickly comes back and they'll tell me. So usually about 2 or 3, 4 times a year, a patient, I don't remember them at all. They're like, oh, Dr. Batiste told me to do this. I lost all this weight. I've been feeling well, but doctor wanted me to have this come over. And I'm like, how did everything look? Oh, it looked good. It looked good. Yeah, everything was still open. Everything was fine. There were no other issues. I think it looked a little bit better. And so it's encouraging for the staff to see it. So when the staff, I'm talking about nurses, I'm talking about techs, and in some instances, doctors, when they really want to know about stuff, they come over, they're like, hey, can I show you my panel? What do you think? What should I
Right.
do? And so I mean it's no longer shocking at all in terms of the outcome. We understand what can happen and they're seeing it. And it's just encouraging to me when they come to me and they'll say, and they're like, if you want to see Batiste smile, don't talk to him about stents or about meetings, talk to him about nutrition, and he's gonna open up and start to kind of just give you a long lecture on everything.
Do you find that that patient, though, is going to stick with that diet for the rest of their life?
It's hard to say. Here's the thing. And this hit me. So just like if you send someone for an enrichment, what ends up happening, they go and they have this huge transformation over 4 weeks, 6 weeks at a living place. They go back home to their family and their friends, and they're surrounded by a community. That's why community is so important. That's why events like this are important. So you have accountability that's there. Not just that, but you have your environment that's so important in terms of what's around you, because we're all going to get stressed. And if every round, birds of a feather flock together, is what my parents always told me as a kid growing up. And if you're always around individuals who are doing everything opposite of what you should do, it's hard to stick to it. And that was something that hit me towards the end of my time in clinic, was that I had these patients coming back to see me, not because they were sick, but because of the fact that they needed to touch, like tag, I'm tagging home, I'm safe. All right, Dr. Batiste, all right, I know you're gonna beat me up. This is what I've been doing. And then they go back out there. It's like taking a deep breath, and it's like, okay, I'm coming up for air. Okay, I'm going back in. And we have to create these spaces for people to non-judgmental, right? Not vilifying, not making it too unattainable, but where it's attainable and there's respect and there's love of saying, let's move you towards an improved state of health, not from a standpoint of you're going to die tomorrow, but from a standpoint we're trying to reduce your risk and help you live the best life you can.
So some of the doctors in the plant-based space talk about an issue with converting DHA to EPA. And we've heard various opinions on that. I wanted to get your opinion on do you see that in your patients who are plant-based, if do they need to take a supplement, or do you find that that's not really an issue?
Yeah, so in terms of like with the megas and so forth, I have not found that to be a substantial issue with my patients at all. I do the primary supplements I recommend for individuals is B12 and vitamin D3. And I'll be honest, it took me a while to come around to vitamin D, just because the evidence has been so variable. It really has been, and not that it's shifted at all. So I believe the issue with vitamin D is not with vitamin D. I believe it's with lack of sunlight, is what I believe. And I believe that we're not, and it's so powerful in terms of what sunlight does. And so when I look at that aspect, that's extremely important. But from the standpoint of the omegas, I'm really once again trying to refine and hone down into what their dietary practice is. And I'm real big, strong advocate of individuals at least periodically, even if you've been doing it for years, record what you eat every so often, once or twice a year. Just track it. And then let's look at your nutrient profile. Let's look at what you're getting in based upon what you think your recall versus what you're actually doing it. And so I'm doing it right now. I'm not literally right now, but I'm doing it right now. I'm in the process of recording down everything I eat, breakfast, lunch, dinner, everything I put in. I weigh it. My wife is like, "You're weighing it?" She had friends at the house and she's like, "You're weighing that small amount of brown rice?" I was like, I am. I'm weighing that brown. I'm weighing. I have a little scale. I do all that stuff because I need to understand. I want, once again, I want to be as objective as possible. Hence the my ring that measures my sleep and my stress, my watch that measures everything. I want to be able to be as knowledgeable as possible so I can make the adjustments. Do I need to increase certain values to help my body?
Do you find those devices accurate and
So the accuracy, I mean, obviously that's a great question. Some are going to be more accurate than others. There's no doubt about it. When it comes to sleep, that's variable because I'm not wearing sleep monitors, official sleep monitors, and having myself monitored for comparison. I do have a sense when I look at overall trends is typically how I use them for overall trends. So look and see what my sleep cycle is like. I look at what my heart rate variability. I can tell you that when I'm in a stressful case or if I'm speaking to highly educated individuals, my aura ring will tell me about my heart rate variability, which is a reflection of stress level, if it's high or if it's low, right? It'll tell me about some of those aspects that are there. And it also gives me a sense of what my baseline, my heart rate recovery is, which is extremely predictive in terms of future events. So I like that. It gives me an automated 6 minute walk test, which gives me a sense once again of my longevity. So all those things are important. I just I like the tools. But you can't rely on any one thing because you're right. There will be levels of inaccuracy that are there.
so just a heads up that last night we had Dr. Steve Blake, who is a Parkinson's specialist, and he has a nutrient tracker, so you can put in your menu and it'll break down what the nutrients are. If you're interested, you can go check out his website. Just look him up.
Yeah, I'll do that. I
So
recognize the names. Oh, maybe it wasn't the same person. There was a basketball player I thought whose name was Steve Blake, played for the Lakers years and years ago. So I'll remember that.
he hasn't mentioned his basketball skills, so I don't think he's the same one.
Okay.
So another one of those, controversies is fruit. Some say lower fruit and some say higher fruit. You talked about berries being great for lowering cholesterol. Where do you stand with fruit in general, and specifically when these people say that fruit should be avoided is within the context of cancer and feeding cancers?
Understood. Understood. So one is, I think berries in my mind fall into a unique category because they have a low glycemic index, a high nutrient profile. They're rich in antioxidants. And so we understand that as they battle the free radicals, which promote cancer and vascular disease, that they're extremely beneficial. That's why they show so much power and promise, whether or not we're speaking about memory, learning for kids, speaking about diabetes, speaking about blood pressure, cholesterol. We see such power inside berries. So I'm a big, strong proponent of berries. How much do you need? A cup a day, right? So that's not very much. That's not high in calories. That's not anyone who's eaten berries. Sometimes they can be sweet, but most oftentimes they're moderate, if not a little bit tart. That's there, and so I think that there's value that's there. I I have not. I'm a big, strong proponent of avoiding ultra processed refined foods because of their impact in terms of cancer and cardiovascular disease. I'm a big, and that dovetails into candy and so forth. All those things are deleterious. I have not found convincing data or data at all that points me that fruit, and specifically looking at these fruits, are detrimental from a large scale or even a randomized view. I'm open to reviewing it if I can receive, but I've seen so much literature about the power of the fruits, the vegetables, the whole grains in terms of disease prevention, specifically cardiovascular, but also looking at cancer too as well.
So you're discussing oil and a study with regard to oil and on a whole food plant-based diet. And I got a little lost in there. I wanted to get some clarification. If you can kind of just briefly go over what the takeaway was with regard to oil.
So the takeaway was that both dietary patterns, whether or not you had about 4 tablespoons or less than 1 teaspoon of oil, showed an improvement in your cardiometabolic profile. So that tells us about the power of a whole food plant-based diet. But what it showed is that the lower oil, or essentially the no oil category, had a greater improvement in their cardiometabolic profile compared to those who consumed any oil. That's essentially what the study was demonstrating. And it was a crossover study looking at the change within the group when they moved from low oil or essentially no oil to high oil. And high oil is relative. 4 tablespoons compared to the general population is markedly less than those in this camp. However, I think the more so from my perspective, the take home point is that I don't want oil to be the thing that says, this is ridiculous. You guys are crazy. I'm not going to eat any of this food at all. I don't want that to be the driver that drives you away. What I want you to recognize is that there has not been studies comparing no oil to oil. This is the first that's along that line, and it does show a benefit towards low oil consumption. That being said, you have to inspect what you expect. We have to check once again. I go back like a broken record. Know your numbers, tailor it according to you as an individual. You as an individual, so you know what the impact is of your actions.
Great. Thank you so much for all the information that you shared with us today. I really appreciate it. It was a great talk.
Yeah, no, I listen. I appreciate you coming with like real questions and showing in terms of like the differences and so forth. And I think the take home point is the fact that I think all of us have to be students. We need to use our common sense, but we also need to be students in terms of the research, the literature, and understand that there is going to be a wide variation in terms of outcomes and abilities. We look at the blue zone, the most long-lived individuals. Well, they're not eating pristinely the way that I might prescribe, and they're living to 100 and thriving and doing well. And it's not to say that there's that, but we also understand that there's so many on that Gaussian bell distribution that are just eating poorly. The majority of us, what we put in has results on the other side. So I appreciate the opportunity. It's been incredible being here with you as well.
Great. If we can unmute the audience so they can share their appreciation for the doctor, please.
Some like
Thank you
radio.
so much, Dr. Batiste.
Helpful and informative.
Every 2 hours, you have to say
A
thank
plus.
you.
A plus.